Good afternoon. Thank you, everyone, for coming. Welcome to the American Hotel, who's our gracious host for these events. My name is Gavin Manu. My wife and I are the publishers of the Sag Harbor Express, and we have been hosting these events, hoping to bring these issues into a casual setting, take them out of boardrooms, and have a nice lunch, a nice casual setting to hear from some experts on the issues. Before we get started, I definitely want to thank our sponsors who've helped us make these events possible. GN Ferraris, the Adam Miller Group, Sag Harbor Chamber of Commerce, the Sag Harbor Variety Store, Attorney John Leonard, the Washwick Agency, BNB Bank, Dayton Ritz and Osborne, Burke and Sullivan, Fisher's Home Furnishings, Harbor Books, and Attorney Tiffany Scarlato. Thank you all very much for helping us with these events. Also, a big thank you to the folks at LTV. They're here today filming these sessions. It's a small room, as you can see, so it's important that we get this word out to a larger audience. So they will be airing this session for those who could not attend. And also in next week's paper, we always offer some comprehensive coverage of this important issue. So definitely pick up next week's issue, and we'll try to explore what we talked about today, and sometimes even some added information. So it's very important for us that we reach a larger audience than those who are just in the room today. So thank you to LTV for helping us do that. Before I introduce our panel, I just wanted to read a couple of statistics that we did a section last week, and one of the stories was about health insurance. The average plan for a single individual now costs about $750 a month, or $9,000 per year, which does not include deductibles, co-pays, and other out-of-pocket expenses that could easily cost another $6,000 or more. Family plans now are running between $2,200 and $2,800 a month. So we're talking north of $30,000 per year, again, before any out-of-pocket expenses are factored in an area like the East End, where it's already difficult to live and just pay rent and be here. You know, when you add these costs into it, it's really a tremendous burden, both for individuals and business owners. Now, the cost of health insurance, of course, is determined by the overall cost of health care. Prescription drug expenses account for 28% of overall spending, followed by inpatient hospital costs, which is about 19%. And according to stats provided by the federal government, healthcare spending in the United States was $3.3 trillion in 2016, which works out to about a little bit more than $10,000 per person. So that's where your formula is set for health insurance from the way I understand things. So obviously, to help us wade through this, we're going to turn to our experts who are here today, and we're just going to offer a question as a means of introduction, and then we'll take some questions from the floor. We do ask that you introduce yourselves and speak into the microphone so that the folks at LTV can get all the questions on the air. So we're going to start with Robert Challoner, who's the Chief Administrative Officer for Stony Brook Southampton Hospital. Robert, there's a microphone right here. Most experts who work in the health insurance industry say the cost of health insurance is determined by the cost of health care. As the Chief Administrative Officer of a major hospital, what are the biggest challenges faced by the healthcare industry in terms of controlling those costs for patients and in turn getting paid by health insurance companies?
Well, thank you, first of all, for inviting me to be part of the panel, and happy lunch, everyone. Eat healthily. I would just, the challenges in terms of that we face certainly are very difficult, and there's no straight line in terms of our costs versus the insurance cost. Clearly, costs for healthcare in this country are going up. When I started my career 35 years ago, healthcare consumed about 10% of the gross national product. That number you were quoting, we're up to almost 20%. And healthcare costs have been rising dramatically. There's a lot of factors that are involved in that. The aging of the population, we use more healthcare as we get older. The complexity, we have technology that we never used to have and we have to pay for. And frankly, the cost of all the supplies and the people. The biggest challenge we face in terms of cost is the human side of it. 65% of our costs are associated with the people that we employ. And you think about any industry that's very, very heavily dependent on people, And these are people that we can't just pull off the street. These are people that require a tremendous amount of education, a tremendous amount of training, and who have an expectation of earning a certain amount of money. Out here, it's complicated, as you say. We have to figure out how to keep them in this very, very high cost area of the world that we live in. And the costs of those people continue to escalate, and have escalated dramatically over the last few years. We have increased expectation of staffing standards. We need to be open 24 hours a day, 7 days a week, 365 days a year. Our emergency room, which is probably second to our OR, one of the most expensive parts of the hospital, has to be open whenever anybody walks in. And all of those people's doctors, nurses, technicians are available, whether 15 people walk in or one person walks in. And the cost of maintaining that has just escalated as if training requirements and staffing requirements have increased. So our costs have risen dramatically. Our costs and our efforts to collect, the second part of your question associated with the insurance companies, I and all of my colleagues up here, I think, would tell you that the system we have is very, very broken. It's a very complicated effort for us to try and collect for the patients that we serve. And a big part of what's driving our costs, frankly, is that complexity associated with trying to collect those bills.
Okay, thank you. Carl Washwick owns the Washwick Agency in Riverhead. Carl, you've been in the health insurance industry for almost 40 years.
I guess I'm old.
You said it, not me. In the current climate, what are some of the most critical things you believe need to change when it comes to this complicated puzzle of healthcare and health insurance?
Okay, what needs to change? When I started in this business, I remember when family health premiums hit $300 a month, and I said, oh my God, who can pay $300? But at that time, a day in the hospital was about $300-400, the room and board charge, and they kind of kept pace. It's really complicated now. What needs to change is obviously it has to be cheaper. $30,000 is unaffordable for most people. So what do? Can you subsidize them? It doesn't bring the cost down. Have to find some way to bring the cost down. My feeling is I'd like to deal directly, get the third-party people out of there. Let me deal directly with my doctor. Let me deal directly with Bob. Just take the middleman out of it, like it used to be when I grew up. If I walk into a doctor's office and say, how much is this visit going to cost? They'll say, oh, your copay is $30. No, how much is it going to cost? I'm not going to get an answer. I'm not going to get an answer. If I walk into my dentist and say, I broke a tooth, what's it going to cost? They'll say $1,200, and you can pay me over 3 months. I don't see why healthcare could be any different, barring emergencies. So more transparency. I think that's the only way to bring the cost down.
Thank you. Erica Garrity is the Director of Revenue Cycle of Peconic Bay Medical Center, and we'll let her explain a little bit of what that means. Obviously, it's another major hospital in our area in Riverhead. What sort of trends are you seeing in terms of patient needs and concerns with regard to coverage of their medical costs, either through health insurance or out-of-pocket funds?
I'll start at the beginning. So I'm the Revenue Cycle Director for Peconic Bay's Physician Enterprise. So that includes everything that really happens outside of the walls of the hospital, or those of you that are familiar with Medicare Part B billing, which is the professional component of all of the services that people receive. The trends that I'm seeing a lot with patients is just not knowing and understanding what their plans cover and don't cover. And similarly to what Carl said, so they're not, you walk into Home Depot, you know what you're looking for. A lot of people go into the doctor, especially if it's for preventive care, which is so important, but they don't know what they're looking for, and they're not even sure what they're really entitled to. I will say I'm a huge believer in preventive care. I think that whether you have insurance or not, if you go and you get a routine physical, women get mammograms, colonoscopies, any of those types of things, any kind of early detection, paying it upfront and first will help a patient later rather than waiting till there's a problem. I think people that don't have health care especially are the population that avoid some of that preventive medicine. When I'm sick, I'll go to the doctor. When I feel like something's wrong, I'm going to go. And it's a bigger hardship for them. There are a lot of things available to people that don't have health insurance. Health savings accounts, if you don't have insurance, is a big piece of it. Pharmaceutical companies that will help patients with prescription costs that aren't otherwise covered. And it's really a lot of self-service on the patient part. So the cost is going up, and the expectation of the patient is also going up. So anything a patient can do to help themselves is really key to future.
Thank you. Yeah, that's a lot of what we're hoping to talk about after we do the introductions is solutions and what patients can do to help themselves. Anthony Cardona is the owner of Cardona and Company in Watermill. He's been in the health insurance industry for nearly 20 years, and he started his own company 4 years ago. Anthony, how do you see the future of your business taking shape in terms of serving your clients? Are there any positive trends that you're seeing?
No. To Robert's point at the beginning, this is a big cost for our country. It's one of the biggest costs, 3.3 trillion, 20% of our GDP, and someone has to pay for it, the $3.3 trillion bill. So one of the things that we look at for people is, we're trying to educate people on is who's going to pay for that bill, and you can pay for it ultimately 3 different ways. One way is in premiums, and that's how most people currently do it. The next way is in taxes, and a lot of people have been talking about that. That would be a single payer system. And the third way would be out of pocket. One of the trends that we kind of are going towards and we're advising people on is, do you definitely want to pay more in premium, or do you want to take some of this cost on as best as the plans allow you to now and set up HSAs and things of this nature? So you have 2 decisions once you choose your network of what provider is going to be best. The first is, do you want to definitely pay the insurance company, or maybe pay the doctor and the insurance company a smaller amount over the course of the year. But as far as the system being 100% fixed, I think anyone would agree at this table, whatever political party you come from, whatever background you come from, it's a broken system as it stands. So getting creative with what we have is all we got to do at the current moment.
Okay, thank you. Fred Theo is our New York State Assemblyman. He's on the campaign trail, so we thank him for being here today. Fred, there's been a lot of conversation about the single payer system. Do you support that kind of program? And what conversations are happening at the state level in terms of the cost of healthcare today and the government's involvement?
Yeah, well, I'll take the second part first, and that will probably lead to the first part. In New York State, basically, New York has been a state that embraced the Affordable Care Act when it was enacted. If you look at New York, they have a full-fledged health exchange program, expanded Medicare, all of those things. So New York, under our current governor, really had went all out to implement the Affordable Care Act. And my experience in my office here locally dealing with constituents is that while there have been certainly some pluses with that, there have also been issues, and there still continue to be issues. Most recently, I've gotten, constituents, small businesses, single, one-person businesses who used to be able to get group plans that can't get them anymore because of language that the state had to incorporate as part of the Affordable Care Act. But on the whole, the issue of the Affordable Care Act has expanded coverage. I think the percentage of uninsured in the state of New York is somewhere around 5 or 6%. So the discussion of single payer, there's been a single payer bill in the state legislature for a long time, and it never got a lot of attention. I think in my early years in the legislature, I'm not sure we ever voted on a single payer bill. When single payer started to get attention in the state of New York, is when the new administration came in Washington and started, and it became a real possibility that the Affordable Care Act might be repealed. And that created concern, pre-existing conditions, all the issues that you hear about. And, it was very close to being repealed. And of course, one of the things that did happen was the penalty provision of the individual mandate, was eliminated. So activity in Washington generated interest in the single-payer bill in Albany. And that bill was passed in the Assembly. I voted for it because I think it's worthy of discussion. It was kind of a no-risk vote as a state assemblyman this year as far as wanting to see further discussion of the issue because you knew it wasn't going to become law. It wasn't going to pass in the state Senate. So, there has been a study that was been done by the RAND Corporation, which is, objective, independent, not-for-profit, that shows that you could expand coverage, you could reduce the cost of health insurance by doing that. So I think that, that's something that we will continue to look at in Albany. Albany is a three-legged stool. There's the Assembly, there's the Senate, there's the governor. The governor hasn't closed the door on single payer. The future control of the state Senate, since it is election time, and I'm not going to say anything that's even remotely partisan. As an independent, that makes it easy for me to do. But the fact of the matter is that in New York State, the control of the Senate will have a lot to do about the debate. The Senate is 32 to 31. There are 31 sponsors for the single-payer bill in the Senate. So, the future discussion of health care and a lot of other issues in New York will kind of depend on what happens in the state Senate. Now, with all of that being said about New York State and single-payer and, the state, we should look at that. We should, everybody's saying it's a broken system. We should look at all alternatives. A couple of issues with regard to single-payer and doing it on a state-by-state basis. One is that to be able to do a single-payer system, you need all sorts of waivers from the federal government. Waivers with regard to the Medicare program, waivers with regard to Medicaid, waivers with regard to ACA. So you basically need the permission of the federal government to be able to do it. And the second part of it that I think really needs to be looked at closely is that the savings it would be generated because you take the profit motive out of providing insurance, and more importantly, you reduce the need for a lot of administration. All the administration that Bob talked about that you need to see who's paying for what and how are they getting paid and all of that. But so people's, they're not going to be paying premiums anymore. If Medicaid isn't a county function anymore, you probably see a reduction in your property taxes. But you need an enormous increase in state taxes, whether it's a payroll tax or an income tax, to be able to pay for that. So, the question is going to be whether or not there's the political will to have that increase in income taxes and, the fear of the unknown. So my sense of it is that it's still something that should be done on the federal level, because if New York's the only state that does single payer, and there may be good reason for us to do that, but you're going to institute a tax structure that may make New York even less competitive than other states, because now it would be a progressive tax. So under the RAND study, 90% of people would pay less, 10% of people would pay more. They're at the upper end of the income level, but you depend on them to help pay for this system. And I think one of the questions is, and we're seeing this on a number of levels, is, well, look around Sag Harbor. A lot of people that may be New York State residents, they have a house in Florida. They may have a house in New Jersey or Connecticut. They change their residency because of this tax. That has an impact on the overall system. And New Yorkers are already being adversely hit by changes in the federal code as far as being able to deduct state and local taxes. So it's complicated, but it is certainly something that is worth looking at and The RAND Corporation study, I think, provides kind of a relatively objective beginning for us to look at those issues.
Thank you. We can see why that bill's been sitting in Albany for so long, I guess. Kevin Luss is the owner of the Luss Group in Southampton. And with his question, I'd like to start getting a little into some more details. With premiums and deductibles and out-of-pocket contributions all seemingly on the rise, some are turning to what is known as catastrophic insurance to cut their monthly costs while also being prepared for a major medical incident. Would you advise your clients to take this path, or are there better alternatives?
I do recommend that clients take a look at this strategy. I myself use this strategy for my own family. It's a gamble, okay? But it is the single best way I know of to minimize your fixed cost. That's the premium that you must pay every month. And increase your variable costs. Those costs you only pay if, in fact, you need health care. So what it enables you to do is perhaps hold on to some of your money rather than give it to the health insurance company up front so they can pay your health costs with it. Like was previously mentioned, most people don't incur as much health care in a year as your premium might cost, okay? So you might feel better paying into your deductible because you're only paying at that time when you're actually sick, okay? Just have to be prepared, because does everyone know what a catastrophic health plan is? Otherwise known as a health plan that's great as long as you don't get sick, okay? Some months you'll only pay your premium, some months you pay your premium and some out-of-pocket costs. It's perfectly suitable for people that it might be a couple, very healthy couple, okay? If you have kids like I do, teenagers, it's a bigger risk. If those teenagers ski and play soccer, it's even a bigger risk, okay? So it requires a little bit of upfront fact-finding and kind of get to know your client and figure out how they view healthcare, how much they utilize the systems. I think part of Bob's challenges at the hospital and any healthcare provider's challenges in terms of collecting debt a large part of it has to do with these deductibles. People are now getting into the emergency room with a $6,500 deductible and saying, shoot, it's not a $250 copay anymore, okay? So these are the things that we have to figure out. There's ways that you can put money away pre-tax and have it sit there for when you need to incur costs, okay? And talk to your accountant about that so I don't get in any trouble. Thanks.
All right, thank you, Kevin. We are going to, now we'd like to take some questions from the floor. Brian Boyhan, who's our partner at the Express, is going to handle that portion. And again, I just want to remind everybody that if you do have a question, we'll bring the microphone over and introduce yourself and speak into the microphone. Thank you.
Hi, folks. Let's first of all, thanks for coming today. I'm sure there are people with loads of questions. I know I do. Anybody on this side of the room have a quick question? All right. Can you just tell us your name?
My name is Geraldine Marola. I'm a homeowner here in Sag Harbor. My children go to OLH. The biggest chunk of my liability insurance is in medical liability, auto insurance, homeowners insurance. I'm paying inflated prices for all these things to cover insurance medically for other people. What I'd like to know is, with universal health care, these things will now be redundant. And will that not in turn create savings in my pocket for me, because I don't have to carry medical liability on my house, on my car, on the school doesn't have to carry it anymore. Everyone's covered. And how will that savings translate into paying for universal care?
Let's see. Carl, I think you got an answer for that.
I've got a partial answer. Oh, sorry. I think I have a partial answer, okay? Your auto insurance, and I agree with you, great question. To the best of my knowledge, no-fault insurance is primary to everything. So they're going to pay first. Everything else pays around it. The cost would come down But there's gonna have to be some legislation or change the rules to flip that around. So the answer to your question right now is, I believe, no, it wouldn't no matter what kind of health care. Okay, since your auto pays first. Homeowner, I'm not sure on. Did that answer your question?
Well, obviously, the medical liability then is required. But, I mean, with universal health care, that being redundant would then be a corresponding change with it.
One would hope, but I don't think so. I just don't think so. It is redundant. There's more layers. So, no
Because you're
fault.
paying twice for the same insurance.
Yes, exactly.
It's silly.
It's redundant. You're paying, one of them you're not using.
Right.
If you're in a car accident and you break your arm, your car insurance company pays the bill. In your health premiums, whether it's universal health care or you buy it on your own or in your HSA, that's still priced in. That is still priced in. Because there's no, you know.
I mean, if we all did things that were just easy, we'd do nothing. I mean, it's not going to be easy, of course, but it's doable.
It should be simpler. It should be simpler.
I agree with you there.
I-
I think that it's to the same point before. The cost will be shifted. It's not. It can't evaporate into thin air. So who's going to pay for that now? Maybe your homeowners and car insurance goes down, but your tax bill will go up by that much. So you have to pay it out of one pocket. Which pocket do you want to pay from, in your taxes every year or in your car insurance every year?
School's liability is going to go down too, so that bill will also go down and then be shifted over to universal.
Correct. It will be shifted. It won't evaporate. And that's, I think, if there's one value that anyone would get from here today, is to see what the real cost is behind our country's healthcare system, not health insurance. I don't think I'm going to convince anyone to feel bad that the insurance companies are the ones that are getting hurt in this. They make a lot of money every single year, but there are some regulations against them, and the numbers that they've come up with are based on the system that we have right now. They're not allowed to just say, hey, you know what, let's make more profit, more profit, more profit. Let us try to make 40% profit. There are guidelines to what profit they could actually make by the amount of premiums they collect every single year. So, and that's usually about 85% of all dollars that are collected have to go back out to actually pay for medical costs. Then 15% go towards their employees' health insurance and their profit line.
Thanks, Anthony. I think Kevin wants to also weigh in.
Yeah, I think a distinction should be made here. I don't think universal health care would bring the costs of anyone's liability insurance down. Okay? Your health insurance covers your costs. My liability insurance covers somebody else's insurance. If you sue me for your health care costs because you've fallen at my house, your health insurance company is going to start to pay for those charges. Then the homeowner's insurance, the liability carrier, will conduct a process whereby they find out who's ultimately responsible. So the healthcare company would be reimbursed by the liability company.
But those people won't have those costs. They're insured. There's nothing to sue you for.
I just don't know if the government's going to want to.
Yeah, but that's not medical. But negligence is different. Yeah.
Yes, John.
Hi, my name is John Leonard. I'm a litigator, and basically what we see in any kind of a negligence action is that a party who is injured, let's say they've come to your home to do some work and they've fallen. Universal health care isn't necessarily going to pay their health expenses in the long run. They may pay them up front, but then always when you have a case in which somebody's injured, all the insurers, the first thing you look for is insurance, and all the insurance companies go after each other. And what winds up happening is that all of these parties will be brought into a litigation, and the health insurer for the individual who's been injured is not going to wind up bearing the cost. It's going to be either the person whose home it is because they didn't have liability insurance, or it's going to be their liability insurer. So at the end of the day, we can't, in a universal healthcare system, expect that because a person has universal healthcare, I don't have to worry about the conditions at my home when I have workers over, or the conditions in my employment, in my place of employment, because there's universal healthcare. My workers, I'm still going to need workers' compensation insurance. I'm still going to need general liability insurance. If I hit you with my car, I'm still going to wind up being required to pay for your health insurance costs. Your health insurer isn't going to shoulder that burden when I'm the one who's caused the accident. So I don't want to say it's naive to think that universal health care would resolve all of those issues, but it's not realistic.
Can I get another question? Anybody in this neck of the woods? Over there? Over there?
Robert Montgomery. I live just outside of Sag Harbor. My wife and I and our daughter, for about 8 years, lived in the UK. My wife and I separately lived another 8 years, so we've spent 16 years in the UK, and we're under the national health insurance structure of the United Kingdom. All I'm going to do is throw out my personal experience. And that is, since we've been back, every year I collect up a 4-inch binder of what in essence is medical paperwork. My 16 years in the UK, I have exactly 0 paperwork. So on the one hand I have, on the one hand I have 4 feet of medical paperwork, and on the other hand, I have nothing. And there's got to be a cost buried into that of, and the 4 feet is just my paperwork. It's not the rest of the paperwork that's engendered throughout the system. There's got to be a cost to that 4 feet of paperwork.
If I can phrase a question of that, what is a way of reducing that? I mean, there is a stark difference between what occurs in the UK and what occurs in the US. Administrative costs, and maybe one of our administrators can address this, have got to be a huge part of the growing cost of healthcare. What is a way of eliminating that or mitigating some of those expenses? Bob?
So, my apologies, first of all, for the amount of paperwork that we send. At our hospital out here, we employ about 1,200 people. Probably 110 of those are employed with helping us track down the administrative costs, or are administrative types that are trying to track down the information. And I'm not going to make any excuses for the system, but I'm going to tell you that when you think about our system from the perspective of everybody in this room, I think except for the Medicare people, if we put you all together and then compared your health insurance plans, your individual needs, all the complexities of all your various plans, it would be mind-blowing. That doesn't exist in England, where there's essentially most people are covered by the national system, and some people buy private insurance. Overwhelmingly, all of us have very, very different plans, and we need to try and navigate our way through every single one of those plans in order to bill appropriately. If we don't bill each plan, it's almost like a custom bill for every person that comes into our hospital. If we don't bill them correctly, we don't get paid, and we get denied for all of those claims. And I can tell you, we spend a huge amount of our time working with all the various insurance companies trying to understand the arcane rules behind their billing. The answer ultimately, I think, is to standardize the billing practices across all of the insurers. I don't know whether we'll ever get to Medicare for all. I don't know if we'll necessarily have one insurer for all, and I'm not even sure that's the correct thing, because even in England, where they've got a universal health care, a lot of people opt out because the quality isn't so swift with some of those programs. But I do think we could come up with a system where the billing and the record keeping and the requirements are standardized across all of the payers, so that people aren't subjected to all this paperwork. And frankly, we would be able to reduce some of our costs if I didn't have to produce a customized bill for every single person that works in my hospital.
Thank you, Bob. Fred? Yes, Fred, I will get back to you.
Sure. I mean, in essence, that, you know, with whether it's the New York health legislation or Medicare for all, I mean, you know, you're providing more health care. So that's not where the savings is. The projected savings, you know, in the, you know, like the Rand Corporation study, that's where the savings is in the administration and in simplifying the administration. So, you know, Bob may be right. Medicare for all, you know, may not be out there in the immediate future. In some sort of standardization of the current system certainly would be a step in the right direction. But administrative cost, you know, because the insurance companies have to have administration, the hospitals, doctors, everybody has to have administration. You know, and your experience is not unique as far as, you know, the whole back and forth of, you know, who has to pay for what, and, you know, paperwork going back and forth determining that. So, you know, that at least, you know, the administration of the system is a big, you know, certainly is a big part of the cost.
Thanks, Fred. Erica, you want to follow up?
I think a lot of it too has to partially do that we live in a pretty litigious society. So, you know, if we're going to do this and now you sign a paper for that, and now we're going to ask you to move over here, so you're going to sign a paper for that. So there's a lot of paperwork relative to consent, and that has to go either to the state government or to the federal government or to the payer. Like you said, it's navigating each individual plan, seeing what they have. But I will say a lot of that paperwork that we give to the patient is for the patient's protection, as well as, of course, our own. I think that what a lot of us do well is informing our patients of what is happening here. I think that we have a lot of laws that really protect our patients, and having all these different payers is why we have that, because there's not one single payer saying this is how everything's going to do. You know, everyone's going to do things the same way. Because we can do things different ways, a lot of those papers are relative to consent.
Okay, thank you. Yes, ma'am. Just identify yourself.
I have read that America's healthcare system is the most expensive in the world, but we're rated 17th in terms of actual healthcare delivery. So first of all, I think it's important for people to understand that and be motivated to do better. And you've got a lot of different examples out there. If we're 17th, you have at least 16 other examples that we could be looking at to make improvements. But my question is, with a single-payer system, could there be any kind of credits for people to lower their payments if they exercised more or ate better or gave up sodas or stopped smoking, stopped drinking, or cut it down to a glass of wine a day or whatever? That's my question.
That's a good question. And your name?
Charlo Taylor. From
Taylor. Charlo has which is an interesting question. Do you foresee, you know, a time where you will be getting benefits, credits, leniency because of your lifestyle choices? And conversely, which is what's happening, I think, in the auto insurance industry, will you be penalized if you don't participate in certain types of plans or certain types of good health practices? Carl?
Okay, Brian, I'll take you back. I've been in this business long enough. Pre-1993 in New York State, April 1st, New York passed community rating law. Before that, if you jogged, if you were healthy, if not smoker, non-smoker, you got charged different rates for your health insurance. So they rewarded you for doing the right things and essentially punished you for not. Along came community rating and everyone paid the same. Exactly. Didn't matter if you were a 300-pound jogger or a 120-pound whatever. It doesn't matter. Everybody pays the same exact thing. So they eliminated the penalties for either bad behavior or bad genetics. But they also took out the discounts for good health. So I think the answer is going to be no on that.
So is that where we are right now at
Yeah.
that point?
My clients, I always said that New York was where the rest of the country would wind up being. Since 1993, nobody in New York had to answer a medical question or pay more because of their health conditions. On the other hand, since 93, nobody got a discount. So it's a level playing field.
Anthony?
To the woman's point over there, our cost of care is the highest in the world by almost double. I believe it's Norway that it's our cost of care, as you mentioned, is $10,600 per person if you averaged it out. The average person spends less than 80% of people in this room spend less than $2,000 a year on their health care. So when you look at the health insurance bill, 80% are paying for the other 20%. In the life insurance industry, we're actually seeing that trend go on more and more. Some of the insurance carriers are actually starting to say, hey, listen, if you wear a Fitbit and things, we could actually monitor the actual, you riding a bike, you eating healthy, sleeping, whatever it might be, and from year to year, your rates could actually go up and down. So we have seen the trend there. I don't know how our government would necessarily be able to monitor who's being healthy, who's not. In other states, things aren't community rated. Like in California, it's age banded. So younger people, I believe they actually do smoker, non-smoker in California too. So they monitor it a little bit. One of the other points that I bring up is we're 16th nation in as far as good care. We're ranked about 34th or 35th in life expectancy. So you would think if we're paying double the amount for our health care, we should be living double as long as everyone else, where the reality is we're not ranked very high. We should be if we're number one in cost, we should be number one in longevity, and we're not. So we have to look to somehow get down that $3.3 trillion bill.
A great question. I'd love to know fundamentally, why is that the case? Why are we at that point? Kevin, you were going to say something?
Well, I was going to say that we won't get to a spot where people get credits for behavior and discounts. It's also been since 1993 that no one has been turned down for health insurance, so we don't want to go there, I don't think. What we could do, however, is there's an argument to be made for cross-state competition between health insurance companies. While the U.S. is the most expensive, New York is one of the most expensive states in the most expensive country. Okay, our doctors are the most expensive. Our people seem to go to the doctor the most. Okay, we take a population of healthy people from Montana and we combine them with people from New York, and we're potentially looking at evening out our premium costs. Okay? We take people from other parts of the country that don't go to the doctor as much and don't go to as expensive doctors as much, and we're potentially looking at combining our costs with someone that's less expensive for an ultimately lower price. I think that's something that should be contemplated.
Thank you. Bob?
Yeah, and if I could say, that statistic that you quoted, as somebody who's in the field, is very troubling, and we are extremely expensive compared to the rest of the world. And there are a lot of things, though, that you have to look behind those statistics, I think. And somewhat it reflects where we put our dollars in this country. We are the most expensive medical care. And we're putting a lot of technology and a lot of people and a lot of spending into the technology, into the medications, into the genomics and the genetic cures and all of these very, very expensive parts of care. And frankly, are world leaders. And sometimes people forget that our health system is the world leader in terms of the development of a lot of these technologies. But what contributes to life expectancy often is things like public health and what we're doing in terms of the early infant care and pediatrics and some of the other services where we're not putting that money. And when you start to average out what's happening in our primary care versus all the money we're putting into end-of-life care, quite frankly, is where you start to see a real problem in this country. And other countries they've shifted the focus. You may not see the emphasis on the development of fancy new cardiac procedures, but you're seeing a lot more money being invested into pre-K healthcare programs. And the question is, are we willing to shift the dollars around in that way?
So the cynic in me says follow the money. And and is the reason that we are not investing in those kinds of programs because they are not as profitable to the industry as other programs?
The industry right now and the funds flow right now, it's absolutely not as profitable. Pediatricians are some of the lowest paid providers in the medical field. Psychiatrists are the lowest paid providers. Primary care providers are some of the lowest paid providers. The young doctors that want to make real money are going into the specialties, and that's absolutely the case, that the incentives right now are all for higher technology, higher specialization, and frankly higher cost care. I don't know how that's up to the politicians and the public policy people to reverse it, but we absolutely are not putting money into the basic public health programs. And the result is we're seeing lower life expectancies. New York State's life expectancy actually dropped over the last year because of lifestyle and the opioid crisis. High technology in hospitals isn't going to fix that. But where is the money going, I guess, is my question from a societal perspective.
Right. I just want to grab somebody back here who hasn't had a question yet.
My name is, can you hear me? Mitchell Brownstein, Sag Harbor resident. So as a sole person, I have to buy my own insurance. Living out here, other than catastrophe, what do you recommend to an individual that has to go out in the marketplace, buy it, does not want to be hit by a whoops going to the hospital and getting a large bill? Is there, number one, insurance coverage out here that's available to me to be covered? And two, what would be the options of a $2,000 premium that covers everything? Does that exist versus a $1,000 premium that I make up the other part in deductibles? So basically, what do you recommend?
Anybody? I'll take it.
Well, I think we have three agents up here who'll be happy to answer that question.
631-283. You know, there's no easy answer to this. I'd want to know things like your income. Odd question, but that determines where we might start looking for health insurance. If you are showing less income, we go take a look at the exchange, where I can get you a subsidy. If you don't want a bronze plan or a high deductible health plan, we take a look at ones with lower deductibles. They'll just cost you more. There's not a heck of a lot to choose from. We have a problem with competition here. We have Oxford, which is a very good carrier, and then we have some others. Okay, that's the way I look at it. I wouldn't necessarily recommend something without finding out more about you, but generally we would take a look at an Aetna plan, an Oxford plan, or an Empire Blue Cross plan.
Anthony?
So we get that call a few times a week, and it's a lot more confusing than one would think. Hey, we're insurance agents. We should be able to come up with something. And a lot of times we have to say, hey, I can't help you. It is what it is, and I hate the answer to that question. But one of the problems, particularly out here, are these exchange plans don't have a good network. And when I help people through the insurance making decision, the first part is network. If the best network, we could get you a plan for $100 a month, but over a sudden I become your doctor, that does you no good. So the first question you have to ask is network. And on the exchange plans, it's really tough to get a good network out here. So this is one of the problems that is very consistent, particularly out here on the East End. Hey, I sold my business. Hey, I retired. Hey, I'm a sole practitioner. I'm a consultant, whatever it might be. Where do and how do I go get coverage? And the answer is a very tough one that a lot of people don't want to hear. You should probably want to go work for the U.S. government. That's going to be the best health insurance you get.
Thank you. Carl?
Well, there is actually a fairly simple answer to your question. You can pay a lot of money for a high deductible policy, or you can pay a really lot of money for a low deductible policy. There's nothing in the middle. Insurance is basically pay me now, pay me later. Okay, as Anthony was saying, with a high deductible policy, maybe you can negotiate. If you wind up in Southampton, they'll work out a plan for you. Okay? The problem is, if you wind up at the drugstore with a $500 prescription and you don't have $500, you're not getting that prescription. So, depends. It's what's most appropriate.
But there are policies out here that, as an individual, you don't have to go, Riverhead or even beyond to. There are policies available to an individual out here that you can go to a local eye doctor or a local physician
Yes.
and not be traveling to Riverhead or beyond.
Yes, and no matter what policy you have, if it's an emergency, it's covered. If you walk into the hospitals here and they don't participate in your plan, they'll take you, treat you, and get paid by the insurance company. Not paid enough, but they'll get paid. The problem is, when it stops becoming an emergency, where do you go? Who do you see? An eye doctor, fine, but if you wanted to see a cardiologist, you probably got a pretty good idea who you want to see. Okay? I can get new glasses, but only one ticker. So there are plans. They're all expensive.
One of the joys of being in a smaller community is anyone that is looking for that help, we're very eager to help you navigate and tell you what we do accept and what plans we're in. And those plans change. There's a couple plans that drop providers, but anyone that does need help navigating, at least the physicians in our hospital and things, we'd be happy to guide you toward those plans. Work with the brokers, obviously, around the cost issue.
Thanks, Bob. Charlotte?
I've heard of some cases where, for example, a 90-year-old woman went into the hospital for something, and it was recommended that she have a hysterectomy, for example. Now, my question is, why don't we have IGs, Inspector Generals, for the healthcare system?
Fred, maybe you want to take that. Why are there not inspector generals for the healthcare system?
Well, there's Inspector General for the state agencies that administer part of the healthcare system. There's a welfare Inspector General in the state. But I think her question is really who's the Inspector General for the medical profession is more what it sounds like, which isn't, obviously there's professional ethics and all of that. I mean, there is a system, but, it is, and there's the issue of medical malpractice, which, by the way, is a big cost driver in this system also. So, there is oversight. My experience with trying to provide more oversight over the medical profession is something that would be difficult to accomplish in Albany, but, it's certainly something that we could look at.
I can tell you that every single bill that goes out does get scrutinized either by Medicare or by the various payers, and if a claim is considered medically unnecessary, we don't get paid, and there's a tremendous number of that. There's also issues where, and I think the implication might be that a doctor is doing something just to gin up a fee or something like that. Those cases do get found out, and there are state regulatory bodies. There's a professional ethics group. There's a number of groups that do clamp down on that stuff very, very hard. And we hear these egregious stories, but I can tell you, as somebody who's been in the business for 35 years, those stories are incredibly rare, and they're always found out. So, we hear the stories that become apocryphal, but there is a very significant oversight of everything that we do in this business already.
Thank you, Bob. We have a question here.
Hi, good afternoon. I'm Kim Folks, and I'm recently out doing my own business called Fork in the Road Marketing Consulting. And I'm wondering for the insurance folks here, what I've recently gone on to the exchange and started to try to educate myself. I've been fortunate enough to work for companies that have provided good insurance. I'm entirely unfamiliar with having to get my own, especially in the recent climate. So it really is a bit of a jigsaw puzzle. I'm wondering for you guys, because you must get a lot of residual calls from people who don't understand it, that do have half a brain, because it's not only understanding what's available to you, but it's also understanding that just because you go on the exchange, it doesn't necessarily mean that I qualify for assistance, for example, because I've made too much money this year to qualify for some of that, number one. I guess I'll get to the question, which is, when people like me call you because I can't make sense of it because I've now called all my providers, including Southampton Hospital, to find out what they take, I can't find a single provider on the exchange that takes everything from the doctors that I've had relationships with for 25 years. So I now have to make choices based on when was the last time I saw so-and-so. So now I have to make choices about, well, I got to go with who my primary care physician takes, because that's more likely the one generally that I'm going to have to go with. And what happens when people like me call, like, how do you all benefit? Because I feel like I don't want to call and waste your time, because I don't know if you're making money on me calling you to help me figure out this puzzle. How does that work? Like, it may seem like but we're all in business out here. That's my point. So how do you all make money if I'm calling you and I end up going on the exchange?
Okay, I'll be quick. Okay, if you're going on the exchange, you're not calling me. If you qualify for a subsidy, and that's the only reason you should be on the exchange, I'll talk to you, point you in the right direction, give you the 800 number, or the 855 number. They're much more friendly to the consumer than the broker. If you don't qualify for a subsidy, get off the exchange, you've got a wider network. How would I make money? I would charge you. We charge $150 for an hour's consultation, because individual insurance pays 0 commissions. And volunteerism is great in the hospital. My employees like to get paid. So we charge you, and honest advice, and I kind of like it because it's unbiased. There's not even a hint of, well, I'll make more money here. Right. Okay? But it's tough if you're a sole proprietor, because you're an individual. Even if you had an employee and you're the only person that wants insurance, your employee has coverage elsewhere through a spouse. Tough. You're still an individual, and your choices are really limited.
Thank you. Kevin, do you have something you want to add?
Just going to say, we don't make money on you, to be honest. The best thing you can hope to do is find an agent that'll just help you, to sit down and help you and serve as a consultant and a friend. Because even if you charge somebody a fee of $150 or $200 a pop to help you, it's still not enough, frankly, okay? Because the right job is to not just sell you the plan, but to sit every time you have a problem and answer the phone and call the pharmacy for you and maybe call Bob's office at the hospital, and maybe he can help you a little bit. In the worst case scenario, we call Fred's office. But Frank,
I'm not sure if I like the way you
but it's difficult. In the past, brokers in New York never worked with individuals. They never got paid. Individuals would just go on their own and go right to Empire or Oxford and buy their own insurance. When Obamacare was passed, it opened up an individual market where we could work with individuals, and suddenly it became another way we could make money. And I think I speak for all three of us when we all tried to do that. And it's something that we spoke of together when we were here before this all started. What do you do with individuals? What do you do with individuals? And you know more than you think. Because as you said, I don't know very much. You explained basically what we would do. You compromise. You don't get all the doctors. You figure out who you've been to the most. I only go to this guy once a year. I only go to her once a year. I'll pay out of pocket. So it's become a big compromise. And it's unnatural to feel like you have to compromise when you pay $700 a month. Thank you. Okay? Exactly. Right. And we feel that. Thanks.
There was other questions. Mary, back here, I think.
Hi, my name is Mary Graves. My question is, I know there's been a dramatic change of administration that we've been living through, but I would really like to hear what you thought of the Affordable Care Act. Certainly there were things that were wrong with it, things that needed to be tweaked. So if this wave that we're experiencing didn't occur, what did you think of the program? What was needed to change to make it better? I thought it was great that insurance expanded for the United States. And yes, I know there are people that were frustrated with it as well. And I would love to hear what you all experienced with that.
Yeah, that's a great question for all of you. And want to start?
I think ultimately with everything, there's pros and cons, right? And there were some parts of it that I think helped the consumer, and some of those parts were, even though I'm sure people are still confused by the plans they buy, there was some degree of transparency. And one of the things that I always kind of try to explain and get people to understand is a few years ago, and not that many, before the ACA, different companies would provide you with different benefits inside the plan. So maybe I switched you from Aetna to Empire or Oxford or whatever it might be, but, and this is a real example, all of a sudden that person's kid wasn't covered for autism under Aetna, but it was for Oxford. And one of the things the ACA did do was streamline a lot of the benefits and inside the plan, so it's not so much different from carrier to carrier, so it's a little bit easier to purchase plans. And I always say, as I've already probably have, you pick your network, and then the second thing that you look at is what amount or what degree of risk do you want to take on. Myself and Fred, one of you guys don't like our political standing and run us over in the parking lot, and we get rushed over to Southampton or Peconic. Ultimately, what would happen is if Fred has the platinum plan and I have the bronze plan, they don't put Fred in the corner room with the beautiful nurses and the rainbows and the unicorns and throw me in the basement with the crazy doctors with rusty syringes and the expired medication because he has the platinum plan and I have the bronze plan. We have the exact same level of care. The only decision the only thing that happens is when we walk out, well, Fred, he's a politician, he's making a lot of money, so he was able to afford the platinum plan. I'm a lonely I'm a lonely insurance agent,
I'll compare income tax.
I have to get the crappy bronze plan. Fred might not have any out of pocket when he walks out. And I might have a $5,000 bill I have to deal with. But with that said, Fred was paying $400 more a month. So one of the things that I do like, and I think it did do and was a positive, was it kind of streamlined the benefits a little bit from plan to plan, whereas before you didn't necessarily know what you were getting. That's one positive that I've seen. The other positive that I've seen is They're, even though you're unhappy with the individual plans, there was a time if you called us, you had no options. So that, you know, that is another benefit I see. Getting people into the system, and by forcing them to have that mandate, in theory, again, I think our system's broken, so I'm not saying ACA was great, but one of the things that it did do was it brought in healthy people and people otherwise who wouldn't have purchased insurance, it forced them to, whereas it's a pool of risk. The more healthy people you get, the more it's going to bring down the cost for everyone. By taking that away, the people who really think they don't need insurance are going to come out, and those people who probably don't need insurance are the ones that, you know, they're collecting the premiums to drive down the cost for the others. But I've seen some positives and negatives. I'm sure my counterparts here have liked and hated it. So,
Fred?
I want my rebuttal here, but I'll leave that alone. But all you really, I think, need to look at is, well, what does the public think? How do they feel about how things have progressed under the Affordable Care Act? Go back 4 years ago. The congressman for this area 4 years was Tim Bishop. The Affordable Care Act was so unpopular, it was one of the reasons why he was voted out of office, because people were upset with the Affordable Care Act. 4 years later, after the Affordable Care Act has been fully, implemented, with its warts and all, the issue in this year's elections is, don't take away our health care. Don't, we want, pre-existing conditions. We want access to health care. And, if you voted to repeal the Affordable Care Act, those are the politicians that are playing defense this year. So I think the marketplace tells you that with its warts and all, and it is not perfect. And as an elected official, I deal with issues where people come to me, they're, whether they're in the exchange or individual market, wherever they are in this, where, they have a problem here, they have a problem there. And there are issues. There continue to be issues. That's why people talk about single payer. But I think 4 years later, as the Affordable Care Act has evolved, I think, the bottom line is most of the public feels like they're better off. To use the old Ronald Reagan line, are you better off than you were 4 years ago? Most people feel like they're better off with the Affordable Care Act than before the Affordable Care Act. And Mary, we'll talk about fishing quotas too, by the way. I still owe you I called you, but we haven't hooked up. So,
Erica and Bob, any thoughts about the ups or the downs of the Affordable Care Act from your experience?
I think that I've been fortunate enough in my career to work with physicians that on their end, it doesn't matter to them what insurance the patient has. They're seeing the patient, they're treating the patient, they're there to diagnose and treat, and then they just say to me, you're there to sort out the rest of it. So I appreciate that from my physician side. I think that affordable care has allowed more people to get the care that they need and really allowed access. From my end, they're paying us less, but but the people are getting treated, and that's what healthcare is about. It's about caring for the patients. We need to maintain, like everything else, it is a business. So we need to keep the doors open 24/7, 365. But to me, it's like with anything else in the world, there has to be balance. So Affordable Care Act is allowing people that otherwise would not have insurance to have insurance. They pay a little bit less. People that are paying high premiums for better health care, and their plans are paying more. And I think that it's really helped balance our community and keep our community healthier, which was the initial goal. It's to keep our community healthy.
Bob?
I would agree with Erica. I mean, from our perspective, we over the last few years, we've seen people getting fewer people being uninsured coming into our facilities. We've seen more people with insurance. They may have high deductibles, so now we may be arguing over the deductibles, but they do have some insurance. And we have definitely seen an increase in people getting care earlier and pursuing relationships with primary cares and an expansion of primary care, getting back to the question of why is our healthcare so expensive and our results so abysmal, because people were waiting until they were really, really sick. And we have clearly seen an entree of people into the system sooner because they're not afraid, because they've now got insurance. And for the first time, we're saying, I've got insurance. Maybe it's time to get that checkup. From public health perspective, I personally think that's a good thing. The system's very complicated. It needs to be tweaked. But I think those basic goals need to be kept in place, and we need to continue to struggle to make sure we get insurance for everybody in this country. It's a shame that we're the only industrialized country that doesn't provide that.
Can I assume that that it is improved in that economic area? Cash flow a little bit for you guys? I mean, were you experiencing, or have you experienced?
No, we absolutely saw a pickup because the number of uninsured people has dropped off, and what's been interesting is it's where we've been able to put that cash flows, and we've seen an expansion in the number of primary care providers we put out into our community, and that's because there's more demand from more people that have insurance. So we've been able to expand that primary care base, that was not the case, 5, 6, 7 years ago when the ranks of uninsured people showing up only at our emergency room were growing.
Mm-hmm. Thank you, Bob. Do you have a question?
This would be for Erica and Bob. In regards to the one-payer plan, would the hospitals be for that then? And would the doctors, do you think, be on board with going that way?
We're struggling with that question as an industry, and I can tell you that right now the New York State Hospital Association is not in favor of a Medicare for all quote-unquote plan. The reasons for that, there's really a couple of reasons. Number one, Medicare, when you look at the people that we serve today, 50% of the people have Medicare. That's essentially Medicare for half the population. Another 15% have Medicaid. About 5% or so have veterans insurance and other. Almost 70% of the people we serve today have some sort of a governmental insurance policy in place. 25% or so have private insurance. About 5% are uninsured. The challenges that we have is that, and where we're talking about this cost escalation and all the escalation we've seen in insurance pricing, it's all been in the private insurance market. So the Uniteds, the Aetnas, the Blue Crosses are all charging more and more and more every year for insurance plans. And they're charging more and more because the dirty secret is we, the providers, are billing them more and more and more and collecting more and more and more from them, because Medicaid has been flat and declining for the last 5 to 10 years in New York State. So has Medicare. We used to be able to break even on Medicare, lose money on Medicaid. We lose money on all the governmental payers with the exception of the Veterans Program at this point. The only place where we make money at this point is with the commercial insurance companies. And as a result, we're totally dependent on their higher rates for us to survive and provide the kind of services that we do provide. The challenge with all payer is, and what we're afraid of, if they put in all payer and they put on all payer at Medicare or Medicaid rates, you will see every single hospital and medical provider in the state go out of business. So it needs to be some sort of a blended rate. And frankly, we're also worried about lack of competition. There is an advantage to the plans vying and providing different things. A single government insured system, while I love the idea of it personally, and I like the idea of the simplicity of it, I worry about the lack of competition. It just isn't our way. We don't do it in our schools. We always have that choice out there, and I would be very concerned about that.
Thank you. Bob, Erica?
I feel very similarly. I think that understanding how it would work first would be important. So my fear with like Medicare for all, and I'm thinking Medicare rates and Medicare guidelines. Right now, Medicare covers medically necessary services only. It's been proven over and over again that preventive medicine is really saving us money in the long run and long term. So to keep our communities healthy, I think really pushing preventive medicine is huge. I think that competition, whether it's among hospital to hospital or payer to payer, and even physician to physician, is important. It helps consumers make choices. So with a single payer, some of the choices that we're able to make as consumers may go away. But I agree, something needs to change. I'm
Thanks.
just not sure.
Fred?
I think that's one, you know, we all look at single payer and we think, well, what about the consumer? But you also have to look at the issue of the provider. And, you know, people say, well, Medicaid's, you know, that's the lowest reimbursement rate. Well, yeah, that's because you all pay for it in taxes. Medicaid is basically paid for, half of Medicaid is paid for by state and county government. And you go to any county executive or any county legislator, and they'll tell you how unfair it is that, you know, the property tax has to increase to pay for the increase in Medicaid. And that's why, you know, there's been an effort on the state level to try to control the costs of Medicaid, because it's a property tax driver. So that's number one. But, you know, if there was going to be a single payer system, and I think the RAND Corporation study that looked at this assumed that there would be a blended rate, that it would be higher than Medicaid and Medicare, but somewhere below what the commercial reimbursement is. And, you know, the politics of this is that, you know, I think it would have to be that way. And I think you have to factor that in when you're assessing the costs and the effectiveness of single payer, because, you know, whether it's Senator LaValle or myself, you know, we love our community hospitals. Bob Challoner and I worked, you know, we talk every week. So if you think we're going to have a reimbursement system that bankrupts our community hospital after all that we've done to get them merged with Stony Brook and pass legislation so that they can have a, you know, build a new hospital at the college campus. I mean, we're not going to do that. So I think that has to be part of, you know, when you're looking at the numbers of single payer, a reasonable reimbursement system has to be part of that equation, because, you know, you have to have providers, and it has to be cost effective.
Thanks, Fred. I had a question over here.
Hi, my name is Mary Beth Armstrong. I'm an acupuncturist in town. And I had a couple comments. One question is, why aren't there more insurance companies? Many years ago, I took a course on insurance billing, and the man said that everyone is basically a trickle down from Blue Cross Blue Shield. And secondarily, I'm curious, why can we only apply for insurance at certain times of the year? And also, I've been in practice for quite a while, and in the beginning, I was covered with a local insurance company. I would send in the form, they'd pay the copay, I'd get reimbursed, and then the insurance company started nitpicking and lying and saying I didn't fill this or that out. And so I'm just curious as to what happened. It used to be, like Bob was saying, simple and easy. You send in the form, you put in the codes, you get your reimbursement, and now everything is so complicated. And it's like so complicated just to apply for insurance. And there's only a couple of companies here that we can even get insurance with. And so I'm just curious how it all kind of went kerflunked.
I can start.
Okay.
And it actually, part of my answer will revert back to a previous question. What's your opinion on the ACA? And I would say that most people that spoke positively about it today, and most people don't have strong feelings about it, I bet, anymore, But I bet if you asked that question 2 years ago, people's feelings would be much more dramatic and much more emotional and much more angry and much more varied, okay? Because we forget about the changeover where we have an open enrollment now for individuals. If you don't like your plan, or if you can't afford it, or your doctor drops out, you can't change your health insurance plan anymore until January 1. Okay, that's a lack of freedom. The lack of competition is a direct result of ACA. Okay, the
Why is that? I'm curious. Why
Be-
is there a lack of competition? You would think there would be more competition.
increased regulations, increased unfunded mandates, and demands on insurance companies reduced the amount of insurance company options we have in this state. Okay? And they go where the money is. They simply pull out of the state. They might pull out of Long Island. They might only sell upstate New York or New York City. They might only have a couple plans here. And that's just a direct effect of the increased regulation of healthcare. Health insurance companies are limited in the amount of profit they can make. So there's a process by which if their loss ratio, or if they pay out less than 20% of 80% of their premium in claims, they have to give some back to the healthcare policy holders. Okay, so these kinds of impacts will all affect everybody in their health insurance plan, like you're seeing now. Reduced competition, increased paperwork, and open enrollment restrictions. And these are the ways they get around when they say they're not going to cover, they'll cover pre-existing conditions. One of the things is they make it so you can't join until January. Okay, so it's all kind of tied in to that.
Thanks, Kevin. Carl?
Okay. To your example of lack of competition, I used to be on the advisory board of a nice little company called Care Connect, owned by North. It was very nice. They are now withdrawn from the market, closed, because they had to pay 46% of their premium income into the risk pool.
And what is the risk?
Risk pool is a fund in the state that covers claims for companies that accept people that are sick already. I'm explaining that very badly, but basically it evens it out. It evens it out. They had to sweeten the pot. You can't stay in business if 46 cents of every dollar that you take in goes out the door. And that's the reason for lack of competition. My opinion of the ACA, I'm going to quote a former president saying it's the craziest thing in the world. The president was Bill Clinton, by the way. Okay. Reason is open enrollment. If everybody had to renew their driver's licenses on the same month, be a hell of a line at the motor vehicle department. The whole country is renewing at the same time. It's going to cause mistakes, backup, inconvenience, and you've got to make a decision when maybe you'd like to think about it for a little bit. You know, my cure.
And who do you talk to? I mean, there's...
Fred. Stagger the enrollments according to birth month, like they do with your driver's license. Even it out. This way you know it's coming.
Yeah, it's just so complicated and frustrating.
It is.
Anthony?
One of the reasons why they do it, right, wrong, or indifferent, is because this whole pre-existing condition situation, and everyone, I think most people would agree that we live in this great country. You should be able to have access to health care. The fight over it is who's going to pay for it. Who's going to pay for it? Are we going to pay for it? Is the government going to pay for it? Is taxes? Are we going to print more money? Are we going to pay out of pocket? Are we going to buy insurance? Whatever it might be. But the reason behind pre-existing conditions is, and I always give this example, and it sometimes excites people, but a traditional insurance company, like a fire insurance company, you have to have insurance for when you get in the accident, right? You can't say, I'm not going to buy insurance. If you have to pay off your mortgage, you don't need to have insurance on your home. But you can't call up the insurance company when your house is on fire and say, hey, I want that insurance now. That's what that's getting rid of pre-existing conditions means. Hey, listen, if I can buy the insurance at any given time, why would you purchase it, before you needed it? And then you would have only people who would come into the system when they needed it. And again, to Carl's point, layering it or doing some way over the course of the year rather than 100% of people, on the same day, or 100% of the people on the same day getting into the system would make, logistic sense. But the reason being is they don't want someone to say, you know what, it's open enrollment, I'm going to pass by, I'm healthy, I'm in good shape, but oh, hey, I was running and I tore my ACL, I'm going to buy that insurance now. The logistics, it would cost a lot of money.
There are short-term insurance options, but they don't cover pre-existing conditions. So talking about the pre-existing makes it tough. The other thing that everybody's familiar with the HIPAA law, and a lot of people think of like patient privacy when they think HIPAA, but it's really health insurance, portability, and accountability. And one of the first parts of that law allows patients, if there's a distinct event, to change insurance outside of that open enrollment. But that event isn't, I don't like my insurance company, or I've not had insurance and I just got sick. But if you were to suddenly lose your insurance, it allows you to do that. If you have a child, you could add it. If you get married, you could add a spouse. So there are some select reasons that you can add it otherwise.
Fred, and then we'll take one more question after that. Fred?
Well, I'm going to follow, go with what you said. Follow the money, because this is about money. That's what it's about, money. Especially this year on the federal level, where they eliminated the penalty for the individual mandate, which was not a popular part of the Affordable Care Act. But the fact of the matter is that if you want pre-existing conditions, you have to pay for it. So that money's not coming in. That money had to be made up. In New York State, I think the average request for increase for insurance, for health insurance premiums, the request was somewhere around 24-25%. Now, if the state had granted that, most of the people in this room would have been calling my office saying, why did you let this happen? What are you going to do about this? So the Department of Financial Services, which regulates that, and are very frustrating to me, and I'm sure to a lot of the people in this room. I think the increase was instead 8%. So the insurance companies, they got 8% instead of 24%. So they've got power, they've got leverage. How do they exercise that? They say, well, if we're only getting 8%, we're not doing this, we're not going to provide this plan, or we're not going to be in New York State or whatever. And that's the balance that, and the legislature obviously doesn't directly involve with the regulation of that. It's in the executive branch. But as a state, I mean, that's the push and pull of all of this. And, and that's why some people favor single payer, because they said, well, take the profit motive out of this thing. Make it, and there are arguments on both sides. But your answer about, competition and why aren't there more companies? Because it's about money. That's what it's about.
Thank you. One last question against somebody who hasn't asked a question yet.
As a small business owner, is there any plan or any kind of network? I just want one person, pay their health insurance. Is there any network or pool other small businesses have, or do I just do a GoFundMe page?
Small pools for small employers? Such a thing exist?
Does not anymore by law.
By law.
It used to exist. You used to be able to form associations form associations and get a plan collectively. That's illegal. You cannot, it is illegal in New York State, correct me if I'm wrong, Fred, to form an association for the purpose of obtaining medical insurance. Okay?
How about if your local chamber of commerce wanted to do it? Can't do it.
No good. No good.
Okay. Yeah. Thank you. I'm going to turn this back over to Gavin. Thank you all for joining us. I appreciate it.
Yes, thank you, everyone, especially to our panelists. This is obviously an incredibly complicated issue, and I hope there's a little bit of clarity today. Again, next week in the newspaper, we will try to break this down a little bit, put it into a cohesive package. And LTV, thank you to them for putting it out there. These guys are our resources, and we appreciate everything. Thank you very much.